This is Joan with the Joan Jerkovich Show at 910 KINA Salina, bringing you innovative talk radio that surprises, entertains, and sometimes informs you. Today we have two guests that are going to talk to us about hospice. And before I introduce my first guest and tell you who my second guest is, I want to give a little bit of a history of hospice. I think most of us kind of understand and know that this is a type of care that we normally might seek for someone who's terminally ill, but it's also a philosophy of care that focuses on palliation of the terminally ill patient's symptoms, and those symptoms are not just going to be physical, they're also going to be emotional, spiritual, or social in nature. And I think that's, again, what kind of delineates hospice from just their medical care by their general physician. And just for some history, Dame Cicely Saunders was a British registered nurse who entered medical school. She emphasized focusing on the psychological and spiritual as well as the physical aspects of terminally ill patients. She began to disseminate her philosophies internationally in a series of tours of the United States that began in 1963. And during her tours of the United States, Florence Wald, who at that time was the dean of the Yale School of Nursing, heard her speak. And she spent a month actually working with Dame Cicely Saunders. And that was who, again, brought the modern principles of hospice care back to the United States. And Florence Wald was instrumental with this in establishing hospice as a corporation in 1971. And then another name that we know, certainly within the medical community, is the Swiss psychiatrist, Dr. Elisabeth Kubler-Ross, who began to consider the social responses to terminal illness. And in her studies, she ended up writing a bestseller that was published in 1969 on death and dying, and it's been quite influential on how the medical profession responds to the terminally ill. Well, our first guest here today is Carol Kuhlman, and she is a chaplain with hospice, and I want to welcome you, Carol, to the show.
Thank you for having me.
Well, welcome, and tell us how you get to become a chaplain for hospice. It's a very specialized type of work.
It is a specialized type of work. A chaplain with a hospice would either be ordained clergy or someone who is certified by their church body. And then you need specialized training on top of that. Specialized training is usually called clinical pastoral education, which gives you kind of the background and the training of someone who would be doing spiritual work in the hospital, hospice, or other clinical kind of setting. We kind of leave our own denominations behind, and we kind of come in as whatever the patient needs and wants at a particular time. We don't come in with our own spiritual agenda. The spiritual agenda is the agenda of the patient and the patient's family.
Well, and that was one of the primary questions I had for you, is how you do that, how that works as far as, you know, treating many different denominations. But do you also run into some people who don't really have a spiritual basis?
Oh, we run into a lot of people who don't have a religious
or spiritual.
Well, they have a spiritual basis, but they don't have a religious basis. And that's kind of two different things. We are all kind of comprised of more than just flesh and blood, or at least most of us think we are. And so a lot of times a person who says, I don't have any religion, I don't want any of this faith talk, I'm good with that. Then let's find out who you are, because that's part of your spiritual process. Dying isn't just about breathing one minute and not breathing the next. It is a process of letting go. And a lot of the work that we do in spiritual care towards the end of life is reconciliation. There are some who say there's 3 needs that you have as you get ready to leave this place for wherever you are going or wherever you think you are going. And that is, you have to be reconciled to yourself. You need to be reconciled.
And what is that actually?
Reconciled with the life that you have lived.
Oh, I see.
Understanding perhaps the life that you have lived, maybe putting it in context, maybe deciding that you did the very best that you could. Maybe you have things in your life that you think, oh man, I need a real redo on this. Not all of us have lived a life where when we get to the very end we say, job well done.
And how do you counsel them with that? Because at this point in the game, there's no redo. There's really not much of a chance, or is there? Is there a way to bring some closure to some of these things that you regret?
I think sometimes for patients, it appears to me that naming those things they regret is enough.
So
and
it's not
sometimes
like
it's not just naming it to me. Sometimes it is the recognition in themselves that, man, I wish I had a redo, but you know what? You don't get one. So you kind of make peace. You kind of begin to reconcile yourself with life is the way it is. I do that, and I'm helpful in that process by a process of life review. We take a look at a whole spectrum of a person's life. Where did they start? Where were they born? You know, what was their family like? You know, and it's not just, okay, all right, let's get to the life review. It's like, tell me where you were, you know, tell me where you grew up. Where did you grow up?
So it's
Maybe,
not like you have your little checklist there that's...
No, I do not. I do have an assessment that I do since we are all Medicare paid.
Yes.
And so Medicare requires that I kind of do some kind of an assessment. My assessment may kind of give me some clues into a person, but no, that's a starting point. And it's like, tell me about your life. What's been important in your life? I begin to see a fuller picture. I only see a real small slice of a person's life. I also work with families.
I was going to say, are the families usually present when you're doing this review? Or is this something you prefer as a chaplain to have as a private moment with the dying patient?
I like to have time with the patient alone. I like to have plenty of time. I like to, you hear the same stories over and over again.
You do?
Very frequently you will hear the same stories. Oftentimes we tend to think that a hospice person needs to be gone in 6 months. It is not always that way. There are times when it may be 9 months, it may be even longer. And yes, when I go, oftentimes I hear pretty much the same story. The importance of that is it is a distillation of what the person's perception of their life is.
So if you were to give us the crystal ball of how we all want to live our lives, because we don't want to be at the stage where we come to see you and have regrets, what are the common regrets that you hear people saying?
I was harsh. There may have been alcohol and drugs involved. There may have been a lack of parenting. There may have been a disconnection with family members. And these are things that may not be voiced as, oh, I regret this, but through the course of talking about family, I may hear him say, well, I haven't spoken to that person in 26 years. And then I may say, wow, 26 years. Do you wish you would have talked to him in 26 years? Have you thought about what you would say to them at this point in time? Sometimes that becomes the fertile ground for saying, yeah, I don't want to talk to him at all. I don't want to do this. But tell me more about that.
Mm-hmm.
Or it might be, yeah, I kind of would like to talk to him. I would like them to know this. Another question that sometimes I will get into as we're talking, what are the things that you want your children to remember about you? This is another distillation question.
Oh, that's
what
a
are
good
those
question.
best things? Because sometimes we all can focus on the raunchy parts of our life. I should have done this, I should have done that. It's not all about what you should have done. Let's look at what you did do. Tell me what you want your kids to remember about you. I want them to remember this, I want them to remember this. Oftentimes they are the things that have been carried even from their very earliest life. I want them to see that I was a really, really hard worker. I want them to know that I tried to provide for them as best as I could. I want them to know I was always there for them, or I always wanted to be there for them. These are the things we want. We want our people to remember about us.
Well, Carol, I think this has been a good start to our interview, and I know this segment seems very short because you even have 2 other points that they like to address, and we'll get to those after we take this little break. But I want all of our guests to be sure and stay tuned. This is Joan on the Joan Jerkovich Show. Be sure to go for our video outtakes, podcasting, and link to iTunes at joanjerkovich.com. And stay tuned for my second guest, Dr. Mark Wiles, who is certified hospice physician.
I was trying to get your attention.
Oh, you got to do right here. I know. I thought you were getting to the...
Here.
Yeah.
Is this my water?
That sure is. Now, what are the other 2, just so I know?
Being reconciled with your concept of God.
So the first is reconcile with self.
Or I mean, they can come in any order. There's
Yeah,
not like a
of course.
magic number.
And then
Some people make with
reconcile
God first. Reconcile with what your concept of God is.
And then the third is?
Is reconciled with the people in your life.
Oh, okay, okay. And what was this category you were calling this again?
I'm calling
There's
it,
3 things
I was
you
saying
read into.
the needs that people have when they're getting ready to leave this place.
Okay, okay, we'll start with that. So I know that seemed to go way too fast. I just wanted to let you keep talking because I'm just like, but this is what's good about the video is even Dr. Wiles, we stayed and talked, you know, a bit more on video.
Where is the camera?
It's right there. Look how cute you are.
Okay, no, I didn't even want to see how cute I am. That's okay. I'm just glad I'm not looking at it. That's good news. Yeah, that's the good news.
Yeah.
We're doing fine. Do you want a 2-minute or a 3-minute or what?
I usually have you do a 3 and then a 1.
3's gonna come quick with 8 minutes.
Yeah, so do a 2 and then a 1.
2 and a 1.
Yeah, you're right.
Okay.
But we'll get to these other 2 needs that people have, because I think that's
That's the perfect word, needs that people have.
Because that's what you told me,
Okay.
so we'll go to that. And I think we're just really getting a good, I know we did spend a little more time with the doctor, but we're getting a good overview of what you do, because you just hit right on it.
And I don't know if we want to talk about the continuum of bereavement, because bereavement starts right at the beginning and continue, but you know, that may be another show.
Well, I had that down, because you do actually do 13 months.
We do.
With your clients, which
We
doctor
do.
talked about that.
Okay.
So I know we've got a little bit of
Okay.
that. So, but we'll go ahead and see how far we can get with these
Okay.
needs. Okay, Ben, you ready? We're back, and this is Joan with the Joan Jerkovich Show. We're here talking with Carol, our hospice chaplain, and I want to get right back into the interview where she was saying that people all have 3 needs that they need to or maybe want to address at this time in their life. So we talked about the first, which is sort of reconciling with their self. What are the second and third, Carol?
Another need would be reconciling with the person's concept of God. Another would be reconciling with the people around them, the people in their life.
And how do you deal with the concept of God when we've already talked about some people don't have that as a personal belief? So when you call that a need of theirs, how would you maybe, and I think that's pretty self-explanatory maybe.
No, I think you're
Or
right, though. I
it's
think
not?
it's really not, because,
I mean,
you know,
especially
some
for people who are believers, but what about the non-believers?
Well,
Because you
even-
work with them as well.
yeah, but even believers, there's a lot of different concepts of God. For those in the Christian realm, for example, there is the very punitive God. There is the God who says, thou shalt do this, this, and this, and if you don't do this, then this will happen. A lot of times people have grown up, they may be 80 years old. The understanding of God when they were in Sunday school was almost like the gatekeeper, and God was a very harsh and punitive person. That may not have worn well with them as they aged, but they've never really articulated that. They've never really said, that's really not the God that I understand anymore. I'm a sounding board for articulating who their God is today, what they believe, maybe they want to tell me what their scriptural basis is. Maybe they've kind of rejected a lot of the common things that they thought years ago, and they have maybe a gentler, kinder God. Then there are people who say, you know, I don't believe in God at all. Well, tell me about that. Tell me more about it.
And what are some of those stories? Because I know people who are like, well, what's going to happen when you die? And I believe we have a soul, and I believe that's my personal belief, but they're like, who cares? You know, I'm just going to be thrown in the ground.
And I have some people who say, you know, I don't think I really
bury me by
believe
the river.
Bury me by the river. Well, there are a lot of people who say, you know, I don't really have this concept anymore of resurrection, which is the common Christian understanding, is a scriptural Christian understanding. I'm starting to really think a whole lot more about reincarnation. And I've explored reincarnation, and you know, it makes more sense to me. Well,
you're talking about personally, or
no,
you're
no, not talking
the
about
person?
the person.
I see what you're saying.
Right, they're saying, you know, that makes more sense to me.
They've begun to look at something different.
They begin to look at something different, and I want to know, tell me more about that. Tell me about your understanding about that. How did you get to that? What did you think when you were a child? So we have some nitty-gritty discussions. I'm not there to change their mind, and I know a lot of people are disappointed in that I'm not there to hold on to the mainstream understanding that they may have had.
Who expresses disappointment in that? Because you are there to serve that person.
Right. Sometimes family members.
Families do too.
Sometimes family members want to make sure that, that the patient has had the appropriate statement of belief for their particular denomination. That
For
would
their
mean
salvation.
Salvation,
Yeah,
exactly. And oftentimes we talk about that word salvation. What does that mean to people? And it gives people a time to articulate where they are. They may be very scriptural, they may be very conservative, very liberal, or they may have beliefs that are off of the mainstream radar. And my job isn't so much to push them in any kind of a direction, but find out where they're going. Some people need reassurance. They say, well, what do you think? I'm pretty evasive. However, I do believe there is something after this life. I do believe we have souls. What that looks like, I'm not so sure.
But you have to keep some of your personal beliefs, as you've said, to yourself.
Or to myself.
Walk that close line.
Right, and reaffirm more of what I hear the person in the family affirming, is what I tend to do.
And then you mentioned the third one, where they need to reconcile with people in their life.
Yes, and sometimes, we think reconciliation might be some big kind of thing where there's a lasting moment of tears being shed. That's not necessarily reconciliation. It can be reconciliation, and that can be a beautiful thing when that happens. But there's also a cognitive reconciliation. Not infrequently will have a family member who is the primary caregiver, who is taking care of a person who was not involved in their life, had alcohol issues early on, left the family, disconnected for years and years and years, may have only come back into the family's life, say, in the last 3 years of illness. How does that caregiver reconcile the years of maybe bad feelings that they have had? I'm surprised at how often family members have already reconciled that. By the time you get there. Yes, and then for them it is a sharing of that. It is a sharing of how they have kind of come to that reconciliation. How they still struggle sometimes of getting angry maybe with Dad, but nonetheless they recognize that Dad did what Dad could do at the time he could do it. And then they'll say, but my brother, so and so, he can't deal with it. He can't deal with it. So everybody is at a different place. Maybe with the patient, the question is, what are the things you would like to say to people? They may say, I can't talk to them.
Oh, wow.
What would you like them to know? Sometimes reconciliation can be in the form of a letter. Sometimes
you encourage that?
Oh,
if they
yes.
feel like, I know I've done wrong here and I can't talk to them.
Or maybe not done wrong here, maybe it's just things that I want to say.
Regrets.
Yeah, maybe
whatever.
I want to say I've loved you as best as I can. It's amazing, almost everybody can say that at the end. I may not have shown it.
And I think that's the truth for everyone.
I think it
Whatever
is the truth for everyone.
Misgivings or personal challenges are, they did the best.
They come down to, yes. And then, we're talking about the difficult things here. So many times it's just affirming where families are. Families are in a good place. They have taken care of their business, so to speak, as life goes on. But oftentimes families need to be encouraged to voice those things.
And Carol, I know that we don't have a lot of time, but I wanted you to speak about bereavement and the process of that, because we only have about a minute left.
Right. In a hospice setting, the bereavement work of the coordinator starts long before the passing of the patient. I began to kind of take a look at the family dynamics. I began to kind of see who may have difficult times with grief, and then I tailor kind of a plan for the next 13 months after the patient passes. We follow families, all hospices follow families for 13 months in one degree or another of bereavement, a 13-month time of bereavement. We do that with personal mailings, but we also have community outreach. We have bereavement groups that are open not just to our patients, but for anyone who has experienced a death through suicide, any kind of loss, can come to a bereavement group and find a place to share their story and to begin their healing journey.
And that's such a good point to end on, because I think that's something that maybe a lot of people aren't aware of, is the support that's so ongoing for all of this family that's been around this person in this difficult time of life. 13 months of bereavement counseling is available if you choose to come onto the hospice program. But we're going to have to break here because this is Joan with the Joan Jerkovich Show. You're listening to 910 KINA Salina. And be sure again and stay tuned for our next guest, Dr. Mark Wiles, who is board certified in Hospice and Palliative Medicine. This is Joan at 910 KINA Salina. Goes so fast.
It does.
We had, like I said, we usually give you a little more time, but we had a really, we had Dr.
Dr. Wiles. He goes and he teaches.
He's a teacher, and he's
teacher.
very, very obviously knowledgeable and passionate. He has a personal passion for such an amazing, personal ministry, really.
And that's what I love.
Yes.
The ministry aspects of that for me. I decided early on that I was probably not cut out for parish work as much. I do a tremendous amount of work in our parish, in our church, but as the leader, I prefer to also be a member. But I like the work. I call it almost marginal, the margins, ministry of the margins. Because it's not ministry with the people who think the same thing that I think and believe the same things I believe.
Right.
It is ministries on my margin. And I like that kind of
And
work.
I would bet there could be some people or some personalities who don't transition with that as easily as you. And there's just all different people out there, and they maybe feel more inclined to proselytize whatever their beliefs are. But you're there strictly to support the family. And I'm sure that's well received too. And who knows, and who knows, that people may have some kind of an awakening or spiritual awareness at the end.
People do.
Are you there when people actually pass away? Do you see moments where you feel? I mean, and this is coming, I guess, from your personal belief. You hear the people that say they saw the angels or heard the angels or things like that. Have you had a sense of an energy transpiring at those times with certain people, or maybe people who have more of that kind of belief? And is that different with someone who doesn't?
I'm not sure. I will say that I've had a number of patients who are speaking to people who are not there.
Oh, yes.
And I believe that they are, whether...
You believe that they probably are, but we don't know if
are.
that's just their brain doing whatever, hallucinating a little bit or whatever. They're on
and
a lot of medications, obviously.
They're on a lot of medications sometimes, yes, exactly. But there does seem to me as though, oftentimes in the transition, the death transition, when we say they are going through transition, it's a time of irritability, it's a time of great restlessness, and you'll have a certain patient who the one thing they're going to do is they're getting up because they're packing their suitcase. What are you doing? What do you do? Well, instead of trying to say, oh, you're not going anywhere, you're right here with me, we just say, where are you going? Well, what can we get for you? What are the things you're going to need? Well, oftentimes you find that they are packing, they are, in their mind, they are moving on, they are transitioning, and they are preparing themselves.
Hear that
and the metaphor that they're using is, I've got to get, or someone else, it's, I've got to get dinner ready. The woman,
I've got to pack, I've got to get dinner ready.
Right. All of these things.
And that's a common thing
you'll see people,
here.
A lot of people will be reaching out.
Oh, reaching. Wow,
but a lot of people too pass by that very end. They're almost in a coma. But I do see smiles.
You see, when the time change, when they take their last breath, they smile.
That there is just, it's a relaxing, I think is what it is, but it is a tremendous amount of peace.
It's a feeling of
peace.
amount of peace.
And that's what families are amazed at, how peaceful families are. And not everyone's death is peaceful. Some have a lot more business that they're taking care of at the end.
And those you find are a little bit more traumatic, maybe.
Yes, for the family.
Now you're talking about taking care of business within their own spirituality or whatever, or within themselves, maybe.
We can kind of assume that. But also some people are, it depends on what body function gives out. And if you take a very young person who maybe has COPD and it's lung issues, oh my goodness, their heart is so good.
And it doesn't want to give up.
It doesn't want to give up. Yeah, and so it's just more strange. I like to think of death as like birth.
Mm-hmm.
You don't get into this world without messiness.
That's a good
You don't
point.
exit either.
Carol, you need to write a book. You really have some great little slogans that you use. It just comes from you know, but you don't get out. You know, birth is messy and so is death.
It is, and it is, and it's hard work, and sometimes
I thought
death
about it
is
that
hard
way.
work also. There's labor involved.
There is
When you
a
get-
laboring.
So anyway,
Well, thank you so much for coming in.
you are very,
bet.
very welcome.
Who's the first half? Sorry.
That's okay. The first half is your chaplain.
Carol, okay, cool.
Yeah. A big thanks to my listeners for staying tuned in to the Joan Jerkovich Show here on 910 KINA. We're here with our second guest talking about hospice today. And our second guest here today is Dr. Mark Wiles. He's a board certified in family medicine and in hospice and palliative care. So I want to ask you, Dr. Wiles, and welcome first of all.
Thanks, Jean.
Okay, let's start over. My
Thanks,
name's
Joan.
Joan. How cute is that? You know what? That was a bad start all the way around, because you know what? I all of a sudden realized that this is going to go up before her, because I'm not going to give all this big history of hospice except in the first segment.
So you're going to put me in the first half?
No, I'm going to put you in the second.
Okay. All right, and it's actually palliative medicine too, rather than care, if you don't mind.
Okay. Okay.
I'll
Oh,
put it.
did I say care?
You did.
Board certified? Okay, we're starting completely over.
Fox News. Coming at you. I told her I'd done live before, and yeah, this is much better.
I agree.
Cool.
I agree. I don't know when I've
With
ever
live
actually
callers
stopped.
even.
Oh,
man.
that's really
Scary.
okay. I'll get my head around it now. A big thanks to my listeners for staying tuned in to the Joan Jerkovich Show here on 910 KINA. We're back here with our second guest, Dr. Mark Wiles, still talking about hospice. Dr. Wiles is board certified in family medicine and also in hospice and palliative medicine. So welcome, Dr. Wiles.
Thanks, Joan. I'm glad to be here.
Well, we're glad to have you. Now, when I hear about you being board certified in hospice and palliative medicine, how many doctors are certified in this? Let's just even say here in the state of Kansas.
You know, there's actually very few board certified in hospice and palliative medicine physicians here in the state of Kansas. If I had to guess, I'd say certainly probably less than 10 in the state of Kansas. Most of them are more located, as you might think, towards Topeka, Kansas City. So very few actually in the central part of the state.
And what drew you to that profession? What drew you to become board certified in this area? It's quite specialized.
You know, even in medical school, I felt a real calling and a draw towards hospice patients. Had spent a great deal of time at the bedside of dying patients at a point in time in my training when that was not really particularly encouraged. There was more to be learned, they felt, outside of that room. And I kind of respectfully disagreed and found myself really drawn towards those patient rooms and ministering to patients at the bedside at that point in time. Also, I think just the dying process is an interesting and not well defined state. When does that begin? Clearly we know when it ends, but it can be very challenging sometimes to understand the factors related to prognosis for patients at the end of life and trying to predict that, as well as many times symptoms that come as part of the dying process that can be sometimes some of the more difficult patients to really try to manage. You know, these are the sickest patients in the world, and so there are plenty of challenges there, I think, to try to overcome.
So in hearing you talk about this, then you were drawn not only to the physical aspects of death and dying, you were drawn, it sounds like, somewhat to what hospice is, you know, kind of out there to do, which is also support the emotional, the spiritual, or even some of the social aspects. Was that also a piece of it, or?
I would say absolutely. I've always, sometimes nurses tell me that I may be part social worker, and I don't take that as an insult. I think that's very much a compliment. I enjoy that social aspect of medicine and working with families, because certainly hospice does take care of families, not just patients. I think the other intriguing thing about managing families is you may have, you're really taking care of people, including families, maybe on their worst day. you're really seeing them at a very vulnerable, maybe the most vulnerable time in their entire life. And so I think that's a real opportunity to try to, grant people a little bit of grace and cut them a little bit of slack, but also help them to become, a little more in line with the goals of care for their loved one as they're sort of venturing towards that next transition in their life.
And so I have to ask, because I'm familiar with hospice, most of us have all heard of hospice, but what do you do as the hospice physician? What is your work day like? What do you actually do? Are you in more of an administrative role within an organization, or are you mostly at the bedside, or are you mostly just trying to coordinate with the family care doctor?
I think all of the above. It certainly can vary on a given day as well. I really enjoy being at the bedside of patients, and certainly patient care is my #1 priority. Many times it may require me to even drive outside of Salina, sometimes quite a little ways, an hour and a half one direction to see a patient at home. I said before that these tend to be the sickest people in the world, and so they're just not generally able to leave their home and come into the doctor's office, or maybe a very long drive for their primary care physician to try to come out and see them as well. So I appreciate the flexibility and the ability to be able to go out and see them where they're at the bedside, or in the nursing facility, for instance. I think that there's a great deal of work that can be done at the bedside, and doesn't always require a visit in the clinic, for instance, to really be able to assess people and again help meet them where they're at. I do have an administrative role too, and there are certain regulations and requirements, paperwork-wise, to be able to comply with federal regulations, just like any other healthcare entity does. And I do help with that administrative role, and do enjoy that, but certainly the patient care is my #1 love and priority.
So does your board certification then teach you through that process about the administrative as well as the role as a physician?
Yes, yeah, I think that was probably the part that I learned the most through that board certification process. It really does cover hospice from top to bottom, including pediatric patients and care of that very unique population that we don't always think about, but certainly there is a need there, and that extra training that comes with that, so that we can be prepared for that. And also just understanding this incredible environment and landscape that we have in medicine right now, and a bit unpredictable, and how hospice kind of fits into that fabric.
Well, and of course, in the first segment we talked about, I gave a little history of hospice, saying how it actually started in 1971, and by the nature of things, that's still a relatively new profession in a sense, and certainly as a board certified hospice and palliative medicine physician, that's very new. What have you run into? Are there misconceptions about hospice?
Yeah, you're exactly right. It is a relatively new specialty. It's only been recognized by by that board certification entity since 2006. So in September 2006 was the first time that individuals could become board certified in hospice and palliative medicine, just like other physicians become board certified in, say, cardiology or pulmonology. So it's considered equivalent, as a specialty now, and that's a very recent development.
That's extremely recent,
yeah,
2006.
Absolutely. I think that, originally, of course, hospice started out as more of a purely nursing profession that was voluntary and at the bedside, and has evolved into this kind of a delivery of healthcare system that's part of this continuum of care that people may really need and really have an entitlement to be able to access, at the end of life. I think it has certainly become much more mainstream, partly because of advances in evidence-based medicine, and there are hospice peer-related journals, just like any other specialty has, studies, for instance, that are done, and data that's tracked on hospice patients, and we understand how these medicines that we use sometimes at end of life, how they work, so that we can better treat patients more effectively, and at what point should we use them. And also, that knowledge helps to advise, their primary care physicians with simply recommendations for their patients, maybe how to manage those symptoms in an optimal way.
And you've mentioned this word, and we've brought this word up a number of times, but I want you to give us a definition of palliative medicine, because we throw that out there and we expect everyone else knows what that means.
Sure. I think there are a number of different definitions of it. I guess the simplest that I could say would be more of a symptom-based delivery system of healthcare. that tends not to be disease-directed. So for instance, a cancer patient may very well receive chemotherapy and radiation that are clearly disease-directed. It's directed at the cancer, and the goal may be very much cure. Palliative medicine, in contrast, is not cure-oriented, but really comfort-oriented, and the treatment really is more geared towards symptoms, specifically looking at, say, the nausea and pain that may come from cancer, as opposed to specifically treating or attempting to try to cure that disease.
Mm-hmm, mm-hmm. And what are some of the admission guidelines? How does someone even know that, you know, hospice is available to them? Because I understand it is paid by Medicare, and I'm assuming other insurance as well as Medicaid, if
Right.
they don't have the financial resources. So what are the admission guidelines to get on hospice?
Yeah, absolutely. It is sometimes a bit of a complex process. I guess to make it as simple as I can, generally patients will, of course, have to have a terminal diagnosis, not always cancer, but there are plenty of other non-cancer diagnoses that people will qualify for those hospice services with. In addition, they have to have a prognosis that's less than 6 months. And that's deemed really to be the case by two physicians, their primary care physician and then also the medical director of the hospice that they choose. So for instance, that would be me. So two doctors that agree that it's likely that they would live less than 6 months. That can be the most challenging part, is the prognosis. If a patient certainly lives longer than 6 months, it doesn't mean that their hospice care ends at that point. They can certainly continue on that service past 6 months. But it's kind of a general recommendation or a general guideline to follow.
And so what would be the reason, and I'm glad you brought up that there are a lot of other disease processes that are terminal, are deemed to be terminal with only 6 months prognosis, but it's not just cancer.
Correct.
It's not just cancer. So why though would someone want to even be on hospice? Let's talk a little bit, about how you coordinate care with their family doctor, as well as, some of the services that are there for the families.
Sure. Well, speaking first to the non-cancer diagnoses, for instance, diagnoses such as COPD or congestive heart failure or even dementia, those are other disease processes that we see at end stages for patients that clearly have symptoms that need to be actively managed. There may be a lot of challenges and limitations there at end of life that make it difficult for them to really receive kind of optimal management of that. Clearly their primary care doctors are equipped and more than capable of doing that, but there may be different barriers that physical barriers, again, because of the fact that they are infirmed and they're simply not able to get to the doctor's office, or the doctor may have limitations on how to be able to get out to see that patient depending on where they're at and located. In addition, I think that there are clearly other spiritual needs and other social needs that come up for patients and families at end of life that oftentimes require a great deal of time, and that often is not a luxury too for primary care physicians. I think as we try to, as a board-certified family medicine doctor too, I've been in private practice actively for 5 years, and so I know exactly what that's like. I think that that optimal kind of coordination of care and recommendations that can come from a specialist as a consultant, just like any other consultant that a primary care doctor might use, those additional recommendations can really help to manage that patient's care in just such an optimal way.
And where do you see yourself and the staff you work with as providing most of this care? Because my understanding is, this can be paid for not only in institutional settings, nursing homes, hospitals, assisted living facilities, but also in the home. So what do you see the trend being where most people are choosing to, let's say, die to end their life?
Well, studies would show that patients' desire is to simply pass away at home. That's a far more common. 80+% of individuals, even venturing close to 90%, would, if asked, would prefer to pass away at home. And I think that maybe isn't a surprise to your listeners. But I think what is a surprise is where those people really do pass away. And most studies would show that about maybe, say, somewhere between 50 to 60%. I think the most recent data I have is maybe 56% will pass away in a hospital. So those things are in
and the other amount pass away in their home.
Either within the home or within the nursing home environment, and so non-hospital locations. So I think there's a real disconnect there between where patients desire to receive their end-of-life care and where that actually happens. And there's a number of complicated factors I think that lead to that, but I think physicians play a major role in that decision, in regards to patients passing away either in the hospital or within their home, and entertaining a discussion about what their goals of care are, at the end of life when they've reached that terminal point in their disease process, whether it's cancer or a non-cancer diagnosis.
Well, and that's going to be a good thing, and we're going to have to take a little break here, but that's going to be a good thing to pick up on, is how do they make those decisions. Some of this discussion, I would assume, once you want it to be taking place before you're in that dire circumstance of all the stress of the illness and of the terminal illness, needing to make these decisions. So we're going to take a little break. This is Joan with the Joan Jerkovich Show, and I want you to be sure and go on my website, joanjerkovich.com, to get our video outtakes, see Dr. Wiles and I here in the studio having our conversation. You can also get podcasts and links to iTunes and also my blogs on the joanjerkovich.com website. We'll be right back on 910 KINA Salina. I have some days when I'm on, some when I'm off, and I feel like off. You're doing great.
Well, that sounded fun.
You're carrying it. You're carrying
Oh.
it. I like this thing about, like I said, coming back. We're going to just get a drink of water here and then head back about, when do you start talking about this? When are families supposed to start talking about this and making some of these decisions? And you talked about it's maybe the physicians that come in, and it was interesting to me that you said the physicians oftentimes will be the ones that might, it sounds like, admit them to the hospital, but is that driven by the family's choice? I would almost wonder, I would think it was more driven by the family saying.
Yeah, yes and no. I think that there may be a perception actually that's allowed to be, I guess, kind of perpetuated to some degree because physicians haven't told them otherwise. They don't know of another choice. My loved one's sick, they need care, that's the only place to get care, so they go to the hospital. So I think that becomes this, just kind of the natural tendency to try to go that direction. But after the 5th time that they've been in the hospital in a month with their congestive heart failure and their symptoms are not optimally managed, the cardiologist every time is sort of maybe even frustrated that they're in the hospital. Says,
what are we going to do?
There's nothing that I can offer you, like you're just here.
Yeah.
So they, maybe get their chest pain under control and then send them back home so that they can bounce back to the hospital again. There just comes a point where the writing is on the wall, and that's where my frustration lies, I think, is that repeated hospitalization and probably not appropriate utilization of resources and just simply not addressing what the goals of care are. Family members may be the ones that are dragging their loved one to the hospital. It doesn't mean that that's where they want to go. Like I said, in fact, the studies would say that that's not where, if there's a recognition that they're really terminal and they're at that end stage, that may be very inconsistent and likely is inconsistent with what the patient would want. Now, there are individuals who, by God, I'm going to the hospital and that's the way it's going to be. They have every intention of passing away in the hospital. Well, if that's consistent with their goals of care, I can't say that I argue with that. But generally, that's not the case.
Interesting. Let me see if I can come up with something. We can get a little bit of that on the broadcast.
Okay.
I think that's very interesting what you had to say there. So Ben, we got another 8, correct? Welcome back, listeners. This is Joan with the Joan Jerkovich Show on 910 KINA Salina. We're wrapping up our conversation with Dr. Mark Wiles, talking about hospice. He is board certified in Hospice and Palliative Medicine. And be sure again to go to the website and listen to the video outtakes. We've had a little bit of conversation at break about just how people maybe sometimes make the decision of where they want to be at the end of life. And I want to jump back into that, Dr. Wiles. How do these people make the decision? You talked about a number of them are dying in the hospitals. Maybe that isn't necessarily their wish.
Yeah, I think that, like I mentioned before, that stat in regards to where patients, if asked, where they would prefer to pass away, and it may be no surprise to people that 80 to 90% of patients may want to pass away at home when that time is right. There may be very few patients who have the goal of their care to simply pass away in the hospital. Some may very well want that reassurance or have that desire to be in the hospital, when they take their last breath. But I would say that generally speaking, most would not.
And this brings to mind something that I think of. What if the patient themselves want to be home, but the family are pushing for extra care, extra intervention? How does a doctor such as yourself deal with that?
Sure, I think that's, I guess, a particular favorite of mine to try to help kind of broker that deal a little between families and patients, and try to help everybody come in line with what the goals of care are that individual patient is. There may be times where the patient may not be able to articulate those goals of care, and so they're trying to really essentially take their best guess at what they think their loved one would want. Families maybe feel very uncomfortable with the idea of caring for the loved one at home for a number of reasons. Spouses may have some hesitation about whether they're really equipped to be able to do that. And I think that's where a hospice team can really shine to help educate and empower families to be able to make a go of it at home, and to see how, what they're equipped to be able to do, and kind of rally the family around it. It can be a real beautiful bonding experience for families, I think, to rally and care for a loved one at home during that time. It can be a bond that can last generations. In contrast, the dying process, if without that kind of guidance, I think, and that comprehensive kind of interdisciplinary care that hospice provides, many times it can become this very bitter, explosive situation for families at end of life, with a lot of guilt and sort of feelings that aren't really well articulated, and it can essentially destroy or erode relationships in families if it's not allowed to be a part of that, a party to that hospice. Things people don't think about too with hospice is that there is a grieving process, that of course ensues after that, and that grief is managed by the hospice team too, all the way 13 months out after that death. That's a service that I think a lot of times people don't always think about, is that there may be some grief that needs to be managed in the wake of that death, and hospice is very well equipped to be able to care for that. In fact, that's simply part of the hospice care experience, is to continue that bereavement for a 13-month period.
I didn't realize that. I didn't realize that at all. So the services continue even after the loved one has passed.
Correct. Even if a person's only on hospice, say, for 2 or 3 days right at end of life, that bereavement period extends 13 months after their death.
So when we talk about certainly this all involvement of the family, maybe a spouse, when you've gotten the terminal illness, the prognosis, the diagnosis of that. So what sort of pre-planning? How do families, should they start paying attention to that and thinking about looking at living wills and advanced directives? Or is that something that maybe their first stop might be hospice, and your team will help walk them through all of that?
Certainly, at any point in time, individuals may, usually at different crises moments, I think, in people's lives, where they start thinking about that. Even maybe even new parents with a young child might start reevaluating what their living will says, or what they would want to have happen. So sometimes it can happen very early on in life. But I would say, generally speaking, most patients tend to think about it when they get into, maybe into their 60s and 70s, or many times it is prompted in the wake of a hospitalization for some specific problem. Maybe mom or dad has fallen and broken their hip, or they are in with their heart attack. And it starts to make them reflect on what they would really want to have happen, at end of life, or if something really did happen to me, how would I want things to go? And so it sort of prompts them, I think, to look at those. So in the midst of a hospitalization, that can be a very common time where people really reflect on their advanced care planning and make some decisions about a living will, or an advanced directive like a DNR, whether they wanted to be resuscitated or not. And at the very least, maybe thinking about who they would want to make decisions for them if they could not. If they could have a signed document called a DPOA, or a durable power of attorney for medical decisions, that can be a wonderful document to really help point towards who the decision maker is. But even if there's just simply a discussion and a general understanding of who that is, that still can be a very powerful tool to really help make decisions in their best interest.
Do you see their doctor, maybe even especially their family doctor they've known for years, being part of that process?
Absolutely. As a family physician, there are a lot of barriers, I have to say, in our defense, to try to really access and help, I think, individuals with that. There may be families that come in for an individual visit hoping for a family meeting. Generally speaking, that day there may be a number of medical needs that really need to be cared for in the midst of that brief doctor-patient visit in the office. And sometimes that's not always the optimal time to really have a family meeting, that may last 30 minutes or an hour. So it can be challenging just from a time, I think, constraint situation. In addition, it can be, you may have family members who have very different feelings about end-of-life care, and they may be in direct contrast to that individual's feeling about them. So I think that's those can be challenges there from a physician standpoint. Many times physicians sort of defer to let patients bring it up. Certainly if they do bring it up, we're more than happy to talk about it. And unfortunately, patients also think it's the doctor's job to bring it up.
Mm-hmm.
And
They do.
subsequently, if neither party brings it up, then it simply doesn't get talked about. Sometimes it doesn't get talked about until it's too late, until that individual is unable to make their own decision and they're suddenly finding themselves on the ventilator in the ICU and you're having that family meeting for the first time. That's maybe not the optimal time to have it.
Well, and you know, I know you and I were talking privately before this interview about, you know, what we all heard of as the death panel, which actually came from Sarah Palin in her political arena, talking back in August of 2009 about how this panel of bureaucrats was going to decide whether her elderly parents were going to get care, whether her disabled child was going to get care. And so with all the political uproar over that, and that issue being politicized, even somewhat incorrectly, in 2011, the American Society of Clinical Oncology bemoaned that and said, maybe we need to take another look at this, because what it really was looking at in the research I did was that they're just looking to actually pay physicians for voluntary counseling of these very patients on these very issues. Do you feel that maybe we would be helping our patients more if doctors were adequately reimbursed for that?
I think that there's at least a chance that that could help to empower that conversation if doctors knew that for that 30-minute or 60-minute commitment, say in the office, that they were going to be paid at a higher level. I think that could be a tool to help them really receive maybe appropriate reimbursement for the time that's really spent for that particular visit. I think also that this idea of death panels, it is unfortunate. I think that kind of comment was made in part because we're really at a point where people are starting to think about advanced care planning more than ever before, and that sort of distrust, I think, makes people, maybe drives a wedge to some degree between patients and their physicians, and it needs to be a time where those individuals are really on the same page and in a partnership, and not a sense of distrust about how their care is being handled to some degree. So I think that is, I guess, a bit unfortunate.
Well, and you and I, again, in that private conversation, talked a little bit about sometimes even among physicians there seems to be a competition for the Medicare dollars, especially if they have something of a conservative attitude that we do know how much health care costs. And so, why do we need hospice? So have you seen any of that or heard of any of that from some colleagues that maybe wouldn't be as prone to refer to your specialty?
I wouldn't necessarily say it would be a level of competition necessarily. I think though that... Or
I meant competition for Medicare dollars.
Yeah, absolutely, I know what you mean. I think that there is a growing sense of, maybe a sense of awareness and even a sense of stewardship on physicians' parts, generally speaking. As it relates to Medicare dollars, they understand that there's this sort of piece of pie that belongs to physicians, and if we're spending or we're allowing maybe spending to occur, largely driven by just the way in which our healthcare system is geared, that there may be this increased expenditure on one area that could potentially make that piece of pie much smaller for physicians. I would argue that it's already pretty small, to be honest with you, and so the idea of further cuts can really impact physicians on a major level, their ability to be able to care for patients in general, just to keep the lights on in the clinic, could be in jeopardy, I think, if that was even lower. So there is a sense of making sure that we secure that, I suppose. I mean, that's just my general sense about things.
And one reason, Dr. Wiles, I wanted to bring that up, because there is some studies to support that hospice actually can conserve Medicare dollars.
Yeah, no question about it. Actually, there's multiple studies that show that, it may be no surprise, again, to your listeners, that the vast majority of healthcare dollars for an individual are really spent in the final, say, 2 weeks of someone's life. For instance, 2 weeks in the ICU is we're talking about sometimes upwards of hundreds of thousands of dollars for an individual. Clearly, if their quality of life is such and they have an acute reversible process that requires them to be in the ICU, by all means, I think that's a very important part of their health care. But for individuals who may be, say for instance, at a very end stage in regards to their dementia, and they have very little quality of life, generally speaking, and say, for instance, they may be on a ventilator or on having a feeding tube or both. There may be just a point in time where there needs to be a reflection on what's an appropriate utilization of resources for that individual. And those are very tough questions, to ask, and very sensitive to some degree. But these are important questions that we're going to have to simply just, like it or not, become much more comfortable discussing, I think, as we move further along. This unprecedented growth of healthcare is just unsustainable. It's remarkable.
Unsustainable, and we can't get away from politicizing it to some degree because there's a limited amount of dollars. And I think too that at least I'm a proponent for hospice, not just for the care that it provides, but also for the stewardship of the financial resources that are limited for all. And that this can help families make those end-of-life decisions. Is there anything you'd like to close on, Doctor?
I think there are, again, certainly a number of positive things about that, and the most of which, and beyond any sort of healthcare savings or other positive attributes for patients and for families, is really, it's just simply the right thing to do. It just is. We all know it intuitively, I think, to be the case, that there comes a point in time, and I think that individuals just need to be equipped and empowered as to really be in control of their health care, or to have families stand beside their loved one as they're making that impossible decision. It's an extremely difficult, vulnerable time for them, and if it is one that they choose to make, and I encourage patients to be very vocal in that, physicians are generally really looking for patients to, in some ways, kind of take the lead. And I think it is time for patients to really take the lead on some of those issues and seek out and access some of those entitlements that they've already paid into. They've paid into their Medicare dollars, and this is just one more entitlement that they're able to access when that point in time is right.
Absolutely, and how empowering that message you've just given everyone, that there's no reason not to call. You deserve this kind of care. You deserve the comprehensive care. Your families deserve this care at this time. Thank you so much, Dr. Wiles.
Thank you, Joan. It's really been a pleasure.
Well, and you've been listening to Joan with the Joan Jerkovich Show. Again, go to joanjerkovich.com for the video outtakes, links to iTunes, and my blogs. And thank you for joining me today for the innovative talk radio that surprises, entertains, and certainly today informs you. It's the Joan Jerkovich Show, 9 a.m. weekends on 910 KINA Salina. I intentionally went over.
That's fine. I mean, whatever.
Yeah. That's what's nice when you're the second guest. If we get talking about something I think is just really, really good, I'm gonna just want to talk more about that. And so,
well, cool.
What do you think? I think it all sounded good. I think it's going to come off real good.